Hello everyone, it's Friday and you're watching Within the Frame. I'm Kim Bo-kyung. South Korea is well known for its solid public health care system, which is more affordable than the systems of many other countries. Doctors' clinics and hospitals are most of the time not hard to get access to, and medical bills are very much affordable. Yet some critical and essential medical departments, such as pediatrics and emergency, are going under due to a severe shortage of workers. The United Kingdom is seeing a similar issue. Its National Health Service, too, is at the breaking point. Reports say hospitals are running well over capacity, while ambulance staff and nurses are staging a series of strikes over pay and working conditions. Why is this? For an in-depth analysis, we welcome into the studio Professor Kim Moon-kyu at Yonsei University's College of Medicine. Professor Kim, welcome.
Thank you for having me.
And we also have David Cox, a health journalist at The Guardian, on the line. David, it's good to see you again.
Thanks for having me in the show again.
All right. Now, Professor Kim, South Korea can boast an affordable public health insurance system with easy access to doctors. But for essential medical fields such as pediatrics these days, I heard that parents are being forced to wait for several hours for their kids to see a doctor, as many pediatrics facilities are closing down. Why is this? Why is this?
As I'm a pediatrician, I'm very sad to see this kind of phenomenon. I understand there are some regions having an open run phenomenon, but we also have to see that there are also areas that pediatric private clinics are going out of business. So this is a paradox. I understand this is kind of an old problem overlapped with a new problem. But we have to look deep into the situation to find the truth. During the pandemic, there was huge decline in pediatric patients visiting a pediatric clinic because we wear masks, we care about personal hygiene and social distancing. So at that time, many clinics already started to close, disappear. And now we are experiencing an increase of patients because this is a spring season and we have an increased daily temperature range. And we no longer care about social distancing. So what is the root cause of this? Why do so many private clinics are disappeared? And I think this is the impact of the pandemic causing a huge financial burden for the private clinics. So as I told you, this is an old and chronic problem overlapped with a new and urgent problem.
Right. So the core of the issue is the financial burden they are going through. Let's take a deeper look at the fees for pediatric services. So the reason behind the severe shortage in the related workforce seems to be, in my opinion, the relatively low fees for pediatric services. And I've heard that the main reason for that is because of the frozen medical rates for over decades. Why is this the case?
Let's go back to the time when we first started this health insurance system. It started in 1977 and it became nationwide in 1989. Medical fee system actually adapted from the Japanese system. And when we look at the medical expense that the patients pay, it's mostly consists of the medication fee. The doctor's fee or the nursing fee takes up only a minor portion of the money they have to pay. And there were a lot of adjustments during many decades, but it was not enough. And I have a data of 2010 comparing OECD countries about the doctor's fee. And Korea is about 1/3 of the average of OECD countries. And when we first started this system, we took the system of the Japan, and the Japan has a yen and we have a won, and the value is quite different. But actually, we took the exact price of the same yen to start with. So at the beginning, was something wrong, and it's not only the pediatrics having the problem. Child-affiliated specialties are having the same problem, pediatric surgery, pediatric urology, everything. So we have to understand special situation when doctors and nurses care the patients. Let's say if we have to take an EKG test for the patient, sometimes we have to sedate, make the children sleep to take the medication, but the fee is the same as the adult. When we have to do the intravenous treatment, it's same as the adult, but it is very, very difficult to find the venous access for small babies. Every aspect, we need more manpower, more skilled personnel, but there is little consideration for this kind of problem. And the portion of the children younger than 15 in our population is declining. I'm so sad that this population do not have a voting right, and it's getting less attention from the policymakers.
Right, I see. Now, David, since we have heard about Pediatrics Department, what they're going through in South Korea, I would like to ask how the health system, especially in pediatrics, being run in the UK. How is it?
Well, in the UK here, we have a different system. So most people don't have medical insurance. Instead, pediatric departments are part of the National Health Service, which is government funded. But because of funding cuts, seeing a specialist pediatric doctor, that's quite difficult at the moment. So basically, hospitals are struggling with the load of patient cases, just like all other departments at the moment. And I think the average waiting time in the UK to get an appointment with a pediatric consultant is nearly 3 months, which is a really long time. We do have the option that if there is an emergency, a child can be taken to a normal doctor where you can get an appointment on the same day, or in really serious cases, you can go to the emergency department. But to see a specialist pediatric doctor, that is proving more and more difficult in the UK right now.
Right, I can see how the similar situation the UK is going through right now regarding the pediatric department. Now, unfortunately, Dr. Kim, pediatric departments are not the only ones struggling right now. There were several cases where seriously ill patients were dying in emergency rooms or while being transferred. And let me give you brief numbers. According to the National Fire Agency, 198 people, that's around 200, they died while moving to other emergency rooms after being pushed back on the priority list between January to July last year. Why are emergency medical facilities having to deal with this kind of difficulties?
I'm so sad to hear that kind of news, and there should be no patient dying on ambulance trying to find proper emergency service. We have a KTAS system, which means Korean Triage Accuracy System, and that makes grade for the patients. How urgent are they? It's from 1 to 5. And 1 is the most serious one, and 5 is a person who it's not necessary to visit the emergency department. And people want to have the service as soon as they arrive, but actually we have to deal with the most urgent cases. And sometimes emergency room is already crowded with many patients. If I look at the OECD data one more time from 2010, the number of the patient visits was divided by the number of doctors. And Korea had 6.45, and while the OECD average was only 2. Which means Koreans visit a doctor very often. And in contrast to UK, Korean doctors are mostly specialists. I mean, we have only a small portion of general physicians. So Koreans have a more high chance to meet the specialist. And as you can see, Koreans visit clinic very often, but that does not mean that Koreans have more severe diseases. According to the OECD data, Korean has the second longest life expectancy among OECD countries. So, one more time, if you look at the doctor's consultation per capita, Koreans have 12.9, while OECD average is only 6. So, there are a lot of doctor consultations, and I have a UK data also, it's only 5. So you can say Korean doctors are working very hard, but the doctor's fee is low. So when you are sick, when you are very sick, you should see the doctor, and but the threshold to visit emergency room in Korea is very low. So you can visit whenever you want. So ER, emergency room, is always busy with urgent and non-urgent patients mixed together. Okay, we have to improve the emergency transport system, and Korea is already well improved because we have a small nation and it's very crowded. It's not so far to reach the emergency department.
Right.
And you can monitor the available emergency room beds, but it does not prevent missing the golden time for treatment. So we have to find another cause and plan to improve this situation.
Right, I see. Now, David, it seems like this is not just the only case in South Korea. Media outlets have pointed out that Brexit worsened the UK's acute shortage of doctors in key areas, leading to several emergency medical facilities being closed. Is this true? And if it is, how is Brexit to blame? And how serious is the situation right now?
So Brexit has definitely been one factor. So to give you some statistics, at the moment, the NHS is around 12,000 doctors short and more than 50,000 nurses and midwives short. But it's not just Brexit. So I think, as in South Korea, in the last couple of years, many doctors, nurses and midwives have quit just due to burnout following the pandemic, and also just with the sheer demands of COVID, finding themselves really overstretched with funding cuts. So then it kind of snowballs and becomes like a very difficult problem to challenge, because you have fewer doctors and then more getting burnt out and more quitting. But one of the problems the UK is having because of Brexit is because it's harder to find doctors from the European Union to replace them, because it's now harder for people to settle in the UK because of Brexit, and that's hit our ability to find doctors from overseas. I think one analysis last year showed that at the moment the NHS would have 4,000 extra doctors if Brexit had not happened. So Brexit isn't the full problem, but it has definitely impacted our ability to tackle these issues at the moment.
Right, I see. Interesting. Now, David, pediatrics, emergency, these are all categorized as essential medical departments as far as I know. And as a journalist specializing in health, what other departments are included in the category? Why are they called essential? And why is having a solid essential medical system so important?
Well, I think, as you said, pediatrics is also extremely important. I think most of us in the UK, we regard essential medicine as being emergency, trauma and critical care, because they're dealing with the most serious cases of all, often patients at risk of dying within a few hours if they're not treated. But I think really all medical departments do classify as essential. It's quite hard to rank one over another. So you've also got oncology, which is vital for the ongoing treatment of cancer cases. And without neonatal wards, there'll be a massive shortage of trained doctors to help pregnant women. So all of these different departments, pediatrics, emergency, oncology, every aspect of the hospital is really crucial to healthcare as a whole.
Right, I see. Now, Professor Kim, to tackle these urgent issues, many countermeasures have been discussed, like increasing the number of critical emergency medical centers, urging medical schools to, increase the student enrollment quota, which apparently has been fixed at around 3,000 for past 18 years, or setting up public medical schools that can mandate residency in provinces for a certain period of time and have students work at essential medical departments, like we have said. Now, how helpful are these countermeasures, and is there more that could be done?
Well, I welcome the good news that our government is willing to put more expense on critical care service, emergency departments, and maybe adjust some medical fees. All through these years, medical society raised the issue about this problem, and the government listened, but there was sometimes no reaction, sometimes minimal reaction. So So we have to see what happens. But through this pandemic, we learned that how difficult it is to build up a critical care service. The facility does not guarantee about it. We need experienced doctors, nurses working together. All of these things does not build up in a short time. So we should have a long-term plan to deal with some of these essential medical service.
Right.
Public medical school, I think it's a wrong terminology. You know, all the medical school is teaching students about public health, and it's definitely a basic nature of medical school. We meet many patients visiting Korea to get treatment from countries who had old Soviet-style medical system. What does that mean? They have high numbers of doctors, medical schools, but the patient does not trust the hospital. These mandatory service system does not work out in a free democratic country. So it only ends up in a poor quality of medical service. And I think essential medical departments are internal medicine, general surgery, obstetrics and gynecology, and also pediatrics. Pediatrics is facing the most problem right now, but in the near future, internal medicine is going to have a similar problem also. So if we have to fix the problem right now before we have overwhelming problems, and well, I hope that we have some improvements and the candidates of the pediatrics will increase in the near future.
Right, I hope so too. Now, David, UK's National Health Service, now that we know it's reportedly in crisis with escalating industrial action coming after years of falling wages and staff shortages, how is the country trying to deal with this issue?
Well, as Professor Kim says, you know, we're facing a lot of issues regarding our health system in the UK at the moment, and we need to take action to try and tackle this as soon as possible. The last few months have been particularly challenging because we've had waves of strikes, really widespread industrial action throughout the winter here in the UK. But last month we seemed to turn a corner a little bit, which is good. So the government and the major health unions representing ambulance drivers, nurses, around 1 million NHS staff, they finally agreed a deal on pay, which is the key thing which all our medical workers were complaining about. They felt they weren't paid enough. However, the one problem with the new deal is that it doesn't include doctors. So junior doctors, they held another strike last month. They want a 35% pay rise, which has declined, and talks are still ongoing, but it's possible that we could see more industrial action from doctors alone, possibly in the next few months. So this is something which the government really urgently needs to try and come to an agreement with lots of doctors over, because that's affecting a lot of medical care across the UK.
Right, I see. Now, Professor Kim, another discussion was actually on adopting the telemedicine service in the country, as this was only temporarily allowed during the COVID-19 era. And the ruling party on Wednesday said that it would try to revise the Medical Act to institutionalize telemedicine services. How do you see this?
Well, actually, telemedicine in Korea was first initiated by doctors group, who cared about the patient in a very remote area like islands. And as we have a high technology right now, I think the era for telemedicine is coming, but I disagree with telemedicine service for a patient I never met before in front of me, or a patient who has a newly developed problem, health issue. And doctors can have very limited responsibility for these kinds of medical service, and this is not the patient want. You may heard about the word, the phrase that life is short, art is long. And actually it was said by Hippocrates.
Hippocrates?
Yeah, and the art means a medical art. That means medicine is very hard to learn, and even myself, I still find shortcomings when I care about the patients. They come with thousands of faces, and sometimes I miss it, so it makes you humble. Patients might welcome telemedicine, but convenience should not be the number one priority. So personally, I think it's premature to begin with telemedicine right now.
I see. Now, Professor Kim, as we are running out of time, I would like to briefly ask you, why should each country's government, in this case South Korea, take most into consideration in order to avoid a workforce vacuum in terms of critical medical fields?
Well, as I told you, the government has to listen to the forefront voices who works at the forefront, and especially the doctors and nurses who care about the critical care. You know, the medical students and internists who want to choose their subspecialty, they don't want to see the patient in ICU or critical care or emergency department. Why is that? The government had to understand why this kind of phenomenon we have right now and do what can they do.
Right, I see. Now, David, how about you? What should UK do to, UK should take most into consideration in order to avoid a workforce vacuum?
Well, at the moment, people are saying that we need to find a more flexible healthcare system. So, for example, because we're missing so many doctors at the moment, if one hospital is really struggling with doctors in a particular specialty, for like regulations to be introduced which allow thousands of doctors to be deployed from other hospitals and basically to be able to kind of like spread our resources of doctors most efficiently. Something else which is being considered is that trying to build more medical schools, we urgently need to train more doctors. And a particularly radical suggestion is perhaps even cutting the time of a 5-year medical degree in order to get more doctors practicing in hospitals. So there's a lot of challenges at the moment, but I think we could see some interesting changes which could help.
Right, I see. I hope all the challenges could be dealt properly so that all the patients could get proper treatment. Unfortunately, this is all the time we have for today's edition, but thank you, Professor Kim, and thank you, David, of course, for your insights. We really appreciate it.
Thank you.
Thank you.
All right, this is all for Within the Frame tonight. We'll be next Monday with more in-depth stories. Thank you for watching. Enjoy the weekend. Goodbye.